everyone for coming to my journal club, and thank you to Dr. Lindsay for being my faculty mentor. So my first article that we're going to talk about today is HIV testing among adolescents with acute sexually transmitted infections. This was published in Pediatrics in 2020. It was first online in March. And the reasons I chose this study was, as part of CHOC, we see adolescents with potential HIV exposures, and this number is markedly higher than I initially realized before reading this paper. And so, as discussed in this paper, STI rates have increased over the past decade, particularly chlamydia, gonorrhea, syphilis, and trichomoniasis. So from 2013 to 2017, STIs in general increased by 31%, gonorrhea increased by 67%, and syphilis increased by 76%. And overall, even with this increase, much of the STI burden is among adolescents and young adults. They only account for a quarter of sexually active individuals, but they make up 1/2 of the incident STIs. So that's why this is an important study to be looking at. And significantly, although the CDC and USPSTF recommends risk-based HIV testing for individuals who test positive for an STI, these guidelines are not adequately followed. So HIV screening rates are as low as 36% among adults, and they are even lower among adolescents and young adults, which is obviously the population that we are seeing. And so what this means is that 44% of 13 through 24-year-olds that are living with HIV actually go undiagnosed. And this leads to adolescent and young adults having the highest transmission rates. So the goals of the study are to examine the rates of HIV testing within 90 days after an incident STI is diagnosed among adolescents and young adults in primary care settings, and also to identify patient and healthcare factors that are related to the receipt of STI and HIV testing. So in terms of types of studies, this is a retrospective study. The way they performed it was they did a chart review from 2 urban pediatric and adolescent primary care clinics that were affiliated with large academic health systems in Philadelphia. Importantly, they only looked at laboratory HIV testing, not rapid HIV testing, because rapid testing was not regularly documented in their electronic health record. So they limited it to a period where rapid testing was unavailable so that they could make sure that they were actually getting all of the HIV tests that were done during that time. And so they also noted in their study that barriers to rapid testing and laboratory testing were likely different. They looked at a period from, one of the centers was July 2014 through December 2017, and the other center was January 2015 through December of 2017. Their participants were aged 13 through 24 years old, and the incident STIs that they looked at were chlamydia, gonorrhea, trich, and syphilis. 87% of their population were African American, and 79% of them were Medicaid insured. Some covariates that they looked at, they split into the patient factors and then into the healthcare factors. So patient factors they looked at were age, sex, multi-pathogen STI diagnosis, and previous STI. And then they furthermore split the age into younger, so 13 to 17-year-olds, and older, 18 to 24-year-olds adolescents, because they hypothesized that older adolescents would be more likely to receive testing. And then healthcare factors that they looked at were adolescent medicine training of the provider, which they described as either completing an adolescent medicine fellowship or a nurse practitioner that was assigned specifically to see adolescent family planning visits, the insurance status, so insured or uninsured, the visit type, so either family planning or primary care, and patient enrollment in primary care at the study sites during the study time. So looking at the data analysis, they looked at the prevalence of HIV testing by calculating the proportion of HIV tests within 90 days of an isolated STI episode They used a couple different ways to do this. So they looked at a bivariate analysis. They used both t-tests and chi-squared tests to measure associations between characteristics of STI episodes and HIV test completion. And then to look at the adjusted associations between patient and healthcare factors on HIV test completion, they used a mixed effects logistic regression models. So they looked at odds ratios that accounted for random effects of subjects and clinic sites. They also conducted models that assessed for associations between patient factors and healthcare factors. And this was because previous research suggested that these things may be connected. And they also included an interaction term between insurance and a family planning visit, because they hypothesized that family planning visits could function differently for insured and uninsured patients. They also looked at a sensitivity analysis. And so this examined if the time since their last HIV test had an effect on whether or not they had another HIV test done when they had this STI diagnosis. So within a subset of episodes, they were able to split this into 3 different groups. So the first group was those who had an HIV test within the past year. The second group was those who had an HIV test more than 1 year ago. And then the third group was those who had no previous documented HIV test. And so they performed similar models as these that we just talked about, and then added time since their last HIV test to determine if this was a factor. And so we'll talk a little bit about what a sensitivity analysis is as part of my statistical aspects of my journal club. So a sensitivity analysis can be defined as a method to determine the robustness of an assessment by examining the extent to which results are affected by changes in methods, models, values of unmeasured variables, or assumptions. And the aim of these are to identify results that are most dependent on questionable or unsupported assumptions. It can also be defined as a series of analyses of a data set to assess whether altering any of the assumptions made leads to different final interpretations or conclusions. So essentially, it answers the question, what if the key inputs changed? So some examples of what a sensitivity analysis could look like are listed in this table, which ended up pretty small on the slide. And those are outliers, looking at missing data, clustering, or competing risks. So what were the results of this study? So the total tests that were performed were 16,392. They had 18,016 positive results, which made up 11.1%. And this was only in 1,313 unique individuals. So less unique individuals than the positive results. So a few people had multiple results from multiple episodes. In terms of the patient demographics, 97.4% were African American and 1.4% were Hispanic. 70.8% were female. The median age was 17, with an interquartile range of 16 to 18. And 27% of patients actually had multiple STI episodes during the study period. Most common STIs in order of diagnosis were chlamydia first, then gonorrhea, trich, and syphilis. So looking at this table, it helps kind of split in down through those that had an HIV test, those that the tests were not done, and then at what point they were either done or why they weren't done. So of those that ultimately had a test done, it was 55.1%, and these are ones that had an HIV test completed within 90 days of their positive STI results. So only one of those was a confirmed HIV positive out of all the completed tests, so that was 0.1%. Of those that did not have HIV testing that was concurrent with their STI testing, approximately 3/4 of those patients did have a follow-up visit, but the majority of them that got HIV testing done actually had their HIV testing done concurrent with the STI testing. So if they were successful at getting their HIV testing done, they were tested all at the same time, not at a follow-up visit, even though a lot of them did have a follow-up visit, but there were less of them tested at that time. And then of the ones that had an HIV test ordered, but their test wasn't completed, some of the reasons were either patients left the lab before the test could be performed, patients did not show up to the lab, there are errors in the medical record or laboratory, the patient declined HIV testing, or the lab was closed when the patient showed up. And so looking at the 3 mixed effects logistic regression models, in terms of results from a patient standpoint, both females and participants with a previous history of STIs had significantly lower adjusted odds of HIV test completion compared with males and those with no previous history of STIs, which is interesting because if you look at data, if they have a previous history of STIs, they're actually more likely with each STI to contract HIV, but these were patients that were less likely to have an HIV test done. In terms of healthcare factors, those that did not have insurance and those that were at a family planning visit were both associated with decreased odds of HIV testing. Interestingly, there is no significant association between adolescent medicine training, enrollment in primary care, or interaction between insurance and family planning visits. And factors that were associated with increased odds of HIV testing included multi-pathogen infection at STI diagnosis. So say patients who had both gonorrhea and chlamydia on their STI tests, and also enrollment in primary care. So those patients that had a long-term relationship with their care provider were the ones that had an increased odds ratio of having HIV tests. The factors that were associated with decreased odds of HIV testing included having that history of previous STIs, being female, uninsured, or having the incident STI diagnosed at a family planning visit. And so looking at the data that they obtained from their sensitivity analysis, participants who had either 1, previously completed an HIV test over 1 year ago, or 2, never had a documented HIV test, had higher odds of getting tested for HIV with an incident STI compared to those who had been tested within the previous year for HIV. And then among those with a previous HIV test, there is an 8% change or of increased odds of being appropriately HIV tested within 90 days of STI diagnosis within each additional month since their last diagnosed HIV test. So the farther out they were from their last HIV test, the more likely they were to have another test. And this is important because the official recommendations are if you have a diagnosis of an STI, you should have a test regardless of when your last test was. So looking at the strengths of this study, the population is somewhat reflective of the adolescents we care for, in that the majority have Medicaid and are also minority populations. And it also evaluated for multiple possible associations that could contribute to HIV testing, and also examined both patient and healthcare factors that were related to HIV test completion. The study did have some limitations in that it was a chart review. It could have missed HIV tests that patients received outside of the electronic health record. So say they, if they were a 22-year-old and they went to their college health fair and they got an HIV test there, that wasn't documented in this. And it also doesn't take into account patients' sexual orientation or their sexual behavior, which is important for recommendations for STI and HIV testing. And so how does this impact my clinical practice? So first of all, if patients are high risk, we want to consider testing them for HIV at the same time as you're testing for other STIs, because this has been shown to have patients have a more likely chance of getting tested for HIV. This is especially relevant if they are either symptomatic, so they're going to have a high chance of being positive on their STI panel, or they've had prior history of STIs, which would also make them more likely for having repeat STIs. You also want to remember that the guidelines recommend testing for HIV in those that are sexually active or those that have an STI, regardless of when their last HIV test. And so, like we mentioned earlier, the study demonstrated in the sensitivity analysis that if those patients had been tested within the past year, they were less likely to get a test, even if they had a repeat STI, which does not follow guidelines. And so we want to remember that even if they've had one within the last year, if they have an STI, we want to retest them. And long-term relationships are important. So those patients that were involved in primary care were more likely to get HIV tests. And so this just emphasizes the importance of having those relationships with our patients and kind of reinforces the positive interactions with long-term care providers and clinic. And the other component that Dr. Lindsay and I talked about were you want to consider bringing them back to clinic for a positive test for an STI. A lot of times in CHOC, if they come back positive for gonorrhea or chlamydia, well, chlamydia, because you can send it to a pharmacy, you'll call them and say, well, what pharmacy do you want me to send it to? And then you send it and they may or may not pick it up. But really, when you bring them back to clinic, then you have that opportunity to sit down with them and go through education. And if you haven't done an HIV test, you can do that HIV test then. And so that really allows for further education and further testing if you take that opportunity to bring them back. And so the last thing I'll do is take this opportunity to go through an overview of the CDC STI testing guidelines for adolescents. So for chlamydia, they recommend routine screening on an annual basis for all sexually active females that are less than 25 years old. It says the evidence is insufficient to recommend routine screening in sexually active young men based on efficacy and cost effectiveness. However, recommends screening sexually active young males in clinics serving populations with high prevalence of chlamydia, such as adolescent clinics, correctional facilities, or STD clinics. And that screening for chlamydia should be offered to young men who have sex with men. For gonorrhea, routine screening on an annual basis is recommended for all sexually active females who are less than 25 years of age. Gonococcal infection is often concentrated in specific geographic locations and communities, so you can target your screening based on that. And this should also be offered to young men who have sex with men. For HIV, this should be discussed and offered for all adolescents. The frequency of repeat screening should be based on the level of risk. And patients who test positive should receive prevention counseling and referral to care before leaving the testing site. And then finally, routine screening of adolescents who are asymptomatic for certain STDs such as syphilis, trich, BV, HSV, HPV, Hep A, and Hep B is not generally recommended. However, you should screen young men who have sex with men and pregnant adolescent females for syphilis. And also keep in mind that in South Carolina, we are in a hotspot for syphilis. So that screening is often included in our testing.
Okay. Hey guys, it's Dr. Lindsay. I can't even see myself. So I just wanted, I guess, to make a few comments. First being that I was a little surprised by the findings of this article. Here you have an adolescent clinic, and they fell short on doing the appropriate screening and testing that was needed for these kids. And, particularly when these kids were showing up to their clinic for family planning, et cetera. So I think, just as Megan was saying, this article really highlights that we really need to pay attention to that and make sure that when we're seeing kids for these types of complaints, that we're really being diligent and making sure that they have appropriate HIV testing. Anyway, I'm going to open that up to any comments, questions.
So, Dr. Lindsay, I think you're right. And I think that I bet you this thing started out as a quality improvement project in their clinic when they noticed that they probably weren't catching some of the HIV screens that they wanted to do. And it's, to me, a great kind of QR project that really shows you the importance of, like, EMRs, right? And how you can leverage an EMR to do the work for you. Because we all think we're really good at remembering stuff, but we're not. We have so much on our plates these days and we're running around crazy that it's easy to either forget to do something you normally would do. And you can leverage things like order sets and EMRs to do this for you so you don't have to remember. It's just part of the routine screening that is happening for them. So I bet you that part of it started out as that. And then the other thing that I was going to say was I would be really interested, because this study was done at CHOP, to see what the influence of people who have ready access to transportation has in that secondary analysis group, right? Not the ones that initially get screened, but the ones that miss screening that come back. Like, do they have access to reliable transportation because they were sending them to labs, right? To have this done. It wasn't done right there at the clinic. And so does that play a factor in this? Because for our patient population, public transportation isn't the same as it is in Philadelphia. And so that certainly would play a key role in terms of getting people back to screening, especially that kind of 16 to 24 age group that may be able to access the transportation by themselves to have that screening done. So I think that kind of secondary analysis and dependent analysis might be interesting for them to look at too. So that's all I have to say about it.
Yeah, I agree, Scott. So if you like, just even thinking about the kids that we have a hard time getting back in Columbia to come back or even respond to us, we have to track them down sometimes. We've had to call schools and all kinds of things to get them to come back in. So just like this study showed, I think doing a HIV test at the onset is going to be really important, particularly those kids, maybe if they're coming in for a complaint, going ahead and doing those, doing that testing before they leave the office is going to be really important. Other comments? Okay. You're good. I'm making everybody busy.
I know. Sorry if everyone has chair vertigo by the time I finish this. Can everyone see me again? Okay, perfect. All right, so our next study is parental hesitancy about routine childhood and influenza vaccinations, a national study, and this was published in Pediatrics also in 2020, originally available online in June. And so the reasons I chose this are obviously immunizations are a routine part of our discussions in the Well Child Check and a key aspect of our role as pediatricians in preventative healthcare. And the World Health Organization designated vaccine hesitancy in 2019 as one of the 10 leading threats to global health. In many countries, vaccine hesitancy leads to lower rates of childhood vaccination, with then associated outbreaks of vaccine preventable diseases, including pertussis, mumps, measles, and kids who get routine vaccinations don't always get the flu shot. And another one of the WHO top threats to global health is the possibility of a global influenza pandemic. So lots of potential subsequent outcomes from kids not getting their vaccinations. So what is vaccine hesitancy? This is really inconsistently defined. Some focus only on beliefs about perceived safety, effectiveness, or the necessity of vaccines. Other definitions include issues of convenience or practical barriers to vaccination. Some experts differentiate between beliefs and behaviors. So they define hesitancy as a continuum of attitudes and beliefs that don't always predict decisions to delay or refuse vaccinations. And then others have used vaccination behaviors themselves to define hesitancy. So we'll discuss some of this in the study's outcomes. So there were 4 main goals of this study. The first was to assess and compare the levels of hesitancy about routine childhood and influenza vaccinations. The second is to assess the relationship between parent-reported vaccination concerns and parent-reported refusal and deferral of routine childhood or influenza vaccinations. The third is to assess parent demographic factors that are associated with hesitancy about routine childhood and influenza vaccines. And then the fourth and final one is to assess the association between socio-demographic and health characteristics and hesitancy about childhood or influenza vaccinations. So the type of study, this was an online survey performed in February of 2019. They recruited families with children that were 6 months, so the age that you can receive the influenza vaccine, to less than 18 years of age. And the population that they were able to get was from the Ipsos Knowledge Panel. So this is actually constructed from a random sampling of addresses, and this created the largest internet-based survey panel. So there's about 55,000 people in this. And the goal of this is that it's really representative of the non-institutionalized US population. It was initially recruited via mail. They do offer small incentives to complete surveys. And then they compare this to the US Census Bureau data to make sure that's actually representative of the US population. So in this study, they first got that data, and then they actually weighted it with the geographic data that the US Census Bureau has from the current population survey to make sure that the study was representative of the sex, age, race, ethnicity, education, census region, household income, home ownership, and geographic region of the continental US. So what this means is that the study was representative of the US population, but not necessarily of our clinic. So 48.7% had bachelor's degrees or higher, and 67.44% were white or non-Hispanic. So study methods and protocols. Inclusion criteria included first, being a parent, step-parent, or foster parent of a child 6 months to 18 years. And second, being able to complete the online survey in English or Spanish. So how did they develop their questions in their surveys? Because I was really interested in how they could actually make a survey be research-based. So they modified the vaccine hesitancy score, or VHS, which was initially developed by the WHO Strategic Advisory Group of Experts on Immunization in 2015. Even though this is fairly new, it's actually been used in numerous countries to assess hesitancy among parents for childhood or adolescent vaccines and among adults for general vaccine hesitancy. It is psychometrically validated, and it encompasses 10 items with Likert responses, including dimensions of vaccine confidence and vaccine risk. The tool has been validated in 2 studies on basis of reported refusal of vaccination. However, it does not include issues of convenience or barriers to vaccination related to payment, transportation, or intercurrent illness, which obviously can be significant sometimes. So the questions included options where they could either strongly agree, somewhat disagree, or strongly disagree. So we'll go over the basic questions now. And they're kind of paired up. So they either are asking about routine childhood vaccinations or the flu vaccine. So the first one is, all childhood vaccines offered by my child's healthcare provider are beneficial. And then the flu vaccine is beneficial for my child. The second is, I do what my child's healthcare provider recommends about vaccines. And then I do what my child's healthcare provider recommends about flu vaccine. The next is, I am concerned about serious side effects of childhood vaccines, and I'm concerned about serious side effects of flu vaccine. Next is, getting vaccines is a good way to protect my child from disease, and getting the flu vaccine is a good way to protect my child from the flu illness. Following is, the information I receive about childhood vaccines from my child's healthcare provider is reliable and trustworthy. And the information I receive about the flu vaccine from my child's healthcare provider is reliable and trustworthy. Next is, having my child vaccinated is important for the health of others in my community. And having my child vaccinated for flu is important for the health of others in my community. Next is, childhood vaccines are effective and the flu vaccine is effective. And finally is, childhood vaccines are important for my child's health and the flu vaccine is important for my child's health. And then the second component of their questions were based on deferral and refusal of vaccines. So they use a question similar to those used to validate the VHS to assess whether concerned about either routine childhood vaccines or influenza vaccines, have led the caregiver to either defer or refuse these vaccines. And they randomly selected members of the eligible panel. This led to the goal was to get 2,000 responses. And they sent out an email with links to these surveys. And then if they didn't get a response, they sent another email 3 days later. So looking at the data analysis, they examined demographics, both with and without post-stratification weights, which were provided by Ipsos to account for differences in responses. So they both looked at the data before stratifying it to try to base it to the US population and after stratifying it. They weighted responses to those questions: strongly agree, somewhat disagree, and strongly disagree. Those numbers that it correlated with were 1, 2, 4, and 5. And then they decided that vaccine hesitancy was greater than 3. So they split up the numbers, and then if it was greater than 3, so either somewhat disagree or strongly disagree, basically, that counted as vaccine hesitancy. And then they calculated unadjusted risk ratios and Poisson regression models with error variance to evaluate the positive hesitancy responses and then look at the dependent variables. So what did they find? So they ended up sampling 4,445 parents, and out of these, 2,176 completed the survey. So they got a 49% response rate, but they did get their 2,000 that they wanted to get. So they found that 6.1% of parents are hesitant about routine childhood vaccination, whereas 25.8% are hesitant about influenza vaccination. So about a 4-fold response in the survey that they did. They found that hesitancy about routine childhood vaccinations is primarily driven by safety concerns, whereas hesitancy about influenza vaccination is primarily driven about low vaccine effectiveness concerns. And the primary significant demographics that led to hesitancy were education level, so a higher education level, and also household income. And interestingly, prior research has found that lower educational level is associated with more concerns about vaccine safety or efficacy, while others have shown that parents with higher educational levels are more likely to forego immunizations or have safety concerns. So even though families with the lower educational level might have more concerns, they're still more likely to get the immunizations compared to a higher educational level who, even though they have a lower percentage of concerns, have a higher possibility of not getting the immunizations. So what were the strengths of this study? It is representative of the US population, and it was done in a standardized survey format that has been verified in previous trials. It does have several limitations. It is a survey, so it's self-reported. Second, the person who's responding to the survey may not be the decision maker for the vaccines. So just this week in clinic, I saw a patient who was living with their grandmother, who was their primary caregiver. However, their dad was technically the decision maker for the vaccine. So this patient had not gotten the flu vaccine because dad wouldn't allow it, even though dad wasn't living with the family and the grandmother was the caregiver. It is not representative of our clinic population, and it also does not include limitations to accessing care, which is a big component, especially for those that we see in our clinic. So how does this impact my clinical practice? First is that in education about influenza vaccination, we might want to discuss more about vaccine effectiveness, as this does seem to be a big barrier to the reasons that families are not giving their children the influenza immunization. It also re-emphasized the importance of discussions with parents regarding the safety and efficacy of vaccinations. And in the COVID-19 era, this will probably become very important as these vaccines are going to be available to younger and younger ages, because these hesitancy questions are going to come up. Are they going to be safe? Are they going to work? Is COVID-19 real, which Dr. Lindsay brought up? all of these people are, these are questions that we're going to get in clinic a lot. So knowing how to have these conversations will be very important. And really the baseline is, what is the family's big concern? And, different families will have different concerns about vaccinations and different reasons not to give them. And so really use this to guide your conversations. It kind of goes back to, having a back and forth discussion and motivational interviewing, which I think sometimes sounds trite, but that's how you can actually, make a difference and kind of have a big impact in these kids' lives. So,
okay, try not to move you guys around too much. So, I think that it's so important, like Megan was just talking about, to know why parents are choosing not to vaccinate, because I think it will allow you as the provider to have just a better informed conversation with them. And how relevant is this article with how much information is on the news right now with the COVID vaccine, particularly as the Johnson & Johnson vaccine, the administration of that has been paused due to significant side effects. I definitely think that we're going to be having those conversations, especially as our young, the vaccines are getting approved for younger children, in the works is definitely kids up to 12. So I think we're going to be having these conversations, definitely more to come. So I think this is a great and very relevant article along that lines. Questions, comments?
This comes up with the HPV.
Mm-hmm.
We were safe.
Well, come on.
But just brings the point that if you talk to them, you eventually convince them to get the
You have to say that later. So I have to speak for Dr. Hahn since he's being camera shy. He's in the room. He was saying that definitely for the HPV vaccine, that has been a big concern, that we have some of the worst rates for HPV vaccination.
And so that came out last year, talking about motivational interviewing and trying to talk with your family about how to do that.
Right.
And now we're seeing probably do the flu, and now it's going to be the COVID vaccine.
Right. So definitely the few of those vaccines that we administer in clinic and recommend, that may be ones that we really need to be able to have an informed conversation for hesitant parents.
So I'll just say one quick thing that I thought this was actually pretty cool, that they, within the discussion part, actually talked a little bit about ordering bias and how surveys can be prone to ordering bias, which is basically the thought of the order that you put questions in can sometimes influence the questions downstream from that. And, certainly surveys like this are prone to sampling bias. The people that really want to answer affirmatively or negatively are going to participate more likely. And the fact that you can have ascent and descent bias and all that. So surveys are prone to problems, but at least this does give you some indication of, hey, there's a difference between the flu and between routine immunizations, at least from what people are perceiving, and how you might approach that motivational interviewing. So I think it's a really actually pretty cool thing just to demonstrate that. The data doesn't really help you a whole lot and tell you what to do, but at least it gives you an idea that there are things out there to think about.
Okay. Other comments? Okay. Thank you.
Enjoy the salsaritas.
Thank you.
Was he?
Good.
Was he at home?
He's at home, rocking a baby.
Yeah, I'm at home. I got to rock a baby.